I'm just going to carry on the next one. All right, so we've all had this x-ray. Patient comes in with a bit of pain in the wrists, and you open up his x-ray packet and you see that, and your heart sinks because you know you're in for trouble. What is the definition of non-union? Essentially, they say more than 3 months, but it's no clear timeline. Essentially, if you're seeing impending signs of non-union, we start getting worried. Why do we get these non-unions? We know the scaphoid is essentially 95% covered in cartilage. There's no periosteum. Doesn't heal with callus. It's all primary bone healing, endosteal. And we know that for primary bone healing, you need rigid, stable fixation. Poor vascularity, distal to proximal blood flow. It's very unstable, crosses the two carpal rows and a small contact area. Just looking at that. So, should we be so despondent when we see these patients? Pinde et al. Last year presented a patient where 80 to 100% union rates for non-union surgery, which seems pretty good. However, it is highly technically demanding, and just restoring just union isn't actually enough. You need to restore the angulation and the length of the scaphoid to correct the dizzy or the instability pattern within the wrist, and for that you need bone grafting, which needs to be often structural bone grafting. And of course, it's a very slow healing process. Non-union rates for a simple scaphoid fracture, 5 to 10%, so it's actually more common than appreciated. Generally, they present in 4 different ways. In this study, they found that there was a group of patients who were treated with a cast, 6 or 8 weeks, diagnosed as united, but in fact, they weren't united. And they presented 5 years later with a non-union. Then there were the fractures who were treated and followed and went on to non-union, which was diagnosed at the time, often around sort of the 5 months. There were patients who were not treated. They often presented sort of earlier, sort of 2.5 years or 2.5 years later. And then there was the defaulting group. And they presented at basically the same time as the other ones that were diagnosed. Of all those different groups, 30% of the patients were asymptomatic, and they were presented with the only reason they were x-rayed is they had a re-injury. So you might say, well, 30% are asymptomatic, do we need to do anything about it? But Ruby et al. Showed that 97% of patients with a non-union, even if it presents completely as an asymptomatic, painless condition, will develop a snack findings or arthritis of the wrist sort of after 8 years. So a well-aligned, painless non-union must be treated. In fact, Lindstrom in their paper said the best indication for stabilizing surgery is therefore the totally asymptomatic patient with no sign of arthrosis. That's when you're going to have your best chance. Just to look, how can we prevent non-union? Obviously, this is the important thing with your fracture. If your fracture is not visible, remember to tell the patient how important it is to re-x-ray at 2 weeks, or to do your MRI or whatever. But you mustn't, in these patients who have the typical history and who have that pain with pinch, and the male sportsman, you must emphasize that they need to come back for that check. And then the other important one is this group, that first group that he presented. The apparently healed fracture at 6 to 8 weeks might not be united. And they suggested that every patient with a scaphoid fracture that's been treated should get another x-ray at 6 months. And they gave this example of one acute fracture treated in a cast for 6 weeks, seemed to be united, and he presented 3 years later and was discharged essentially there, and presented 3 years later with this non-union. And that was a significant group of patients that they found. Other important thing is to identify risk factors for non-union. Proximal pole fractures, because we just know that the rate of AVN is so much higher. Displacement, that vertical oblique pattern that we talked about previously. Angulation on the lateral, so that goes with your dizziness, the instability that you have. Comminution, also potential for AVN. Perilunate dislocations, there's been so much disruption within the wrist that the blood supply and is damaged and they're very unstable. So we're talking about the instability again, and smoking. We always obviously throw that one in. So they've been classified by Slade and Geisler into 6, but it's a bit difficult, and I think essentially I look at them in these 4 groups. Early non-union, established non-union, poor prognosis group, and your patient that already has OA. Established OA is probably the easiest group. We classify them according to the SNAC classification and treat sort of accordingly. So your SNAC 1, you treat as an established non-union, but you might need to do a stylodectomy as well, and you try and get the scaphoid to unite. SNAC 2, 3, and 4 have their own treatments, and that's obviously for a different talk. Your early non-union may also be called a delayed union. 8 to 12 weeks of casts, but starting to show signs of cyst or resorption, some sclerosis. Also patients that present sort of after 3 months with no treatment. These patients generally just need, but the scaphoid, importantly, the scaphoid is aligned. It hasn't displaced yet. They really just need stabilization to heal. Much like a hypertrophic non-union, as soon as you give the stability, the fracture can unite. That can generally be done by percutaneous fixation. Question is, don't we need a bone graft? We're talking about a non-union here. Essentially, it's been shown that doesn't look like we need to do a bone graft. What some authors are doing is taking off the drill, like that was shown yesterday, take the bone off the drill, put it down the hole where your screw is going to go in, and then and fix it. If you have done these, you'll know that sometimes you open up. You see on the X-ray, you see the line, but when you open up, you don't see anything. You can't see the fracture site. So then, what do? You take your image and you take your drill and you try and put it over where you see on the line on the X-ray, and you drill a hole and you try and stick bone graft in there, and you may be doing more damage actually. So this year, Picor and Carides presented a paper at COMOC, increasing the scope for percutaneous fixation, and this is essentially, they was talking at these, they called them established non-unions. I think I would call them that sort of early non-union group, going towards the established non-union. So they've extended their indication to include fractures, delayed presentation with this non-union sort of looking like that. Obviously, appropriate patient, there mustn't be any displacement of the fracture or angulation. And this patient, they used to treat that with a bone graft. These days they would just put a screw across that. So we can extend our indication for these undisplaced non-unions to just doing a percutaneous fixation. So this is the big one, the established non-union. Got bone loss, got your big humpback deformity, your wrist is collapsing into a dizzy, you've got sclerosis, you've got cysts. What to do here? Essentially, we need a CT scan to plan our surgery. If you suspect AVN, because AVN changes you from one group to another group. So if you suspect AVN, do an MRI scan. But with well-performed surgery, we can still get a reasonably good rate of union. You need to do a corticocancellous strut grafting. You need to correct the length and correct the angulation of the scaphoid. And you need to internally fix it. So you need to get the scaphoid get rid of this humpback over here. You need to rotate the scaphoid straight like that. Put in your triangular wedge graft volarly to get the scaphoids out to length. Then your internal fixation for stability and compression. You must correct this intercarpal alignment. Otherwise, you still have your collapsing of your lunate, and you can still have pain and arthrosis of the wrist. So there's a patient, there's the graft, 6 weeks, then at 4 months, united nicely. Then the third group, this poor prognosis group. So these, you need to look for these things. AVN, put you immediately into this group. Revision surgery, previous failed surgery. Your proximal pole non-unions, comminuted fractures. The problem is here that you've also lost biology, and you need to bring in vascularity and osteogenic potential. And for that, you need to use a vascularized bone graft. These can be pedicle or free grafts, but the papers have shown an improvement of union from what used to be 47% with just a non-vascularized bone graft up to as high as 88% with a vascularized bone graft. Technically, it's very difficult, and some people don't believe that it's always works. When you turn that little flap, the vessel is absolutely minute, and you can just imagine it's just going to taut and obstruct the blood flow. But there are lots of patients that advocate. You still need to do a good debridement of the non-union site. You have to correct your alignment and correct the dizzy, correct the length, and you need rigid internal fixation. So your proximal pole fracture, your AVN, that's not going to heal unless you bring in some new blood. So your vascularized bone grafts can either be pedicled, and the most well described is the Zeidenberg, comes off the radial styloid, and it can either go to the dorsal or to the volar side, or you can do a free graft from the distal femur. But obviously you need a microvascular anastomosis for that. All right. Thank you.
Thanks, Grant.